We'll listen to now Professor Sandeep Saxena, and he will be talking about Eels disease.
So as Dr. Malay said, that Eels is a prototype of vasculitis and neovascular confluence, and I'll be dealing with this subject. As we all know that retinal vasculitis has a number of causes, and some of them are mentioned over here, but still I will be focusing on Eels disease, which is a disease of our part of the world. So it's prevalent in India, Southeast Asia, some part of Eastern Europe, and somehow it has a male predominance. The disease is characterized by a triad of retinal periphlebitis, capillary non-perfusion, and neovascularization. So I'd like to just present for the audience the clinical spectrum of the disease, which you can see over here. That you can see superficial retinal hemorrhages and associated periphlebitis. Here, the things are still more florid, and you can see a venous occlusion which is associated with periphlebitis. Here is another example as the things progress and the disease goes into the proliferative stage. You can see multiple NVEs and associated macular edema also in this case. And finally, some of the cases present as central Eels disease, which is basically papillophlebitis, which is associated with vasculitis. Now, the lesions show up very well on fluorescein angiography, and here you have a confluence of inflammation and vascularization. You have an NVD, a neovascularization of the disc, an NVE, and associated leakage of the dye from retinal periphlebitis. So this is a very good example, and here you can see that besides vasculitis and neovascularization, you have large areas of capillary non-perfusion. So due to vasculitis and decreased vascularization or hypoxia, as mentioned before, the capillaries have been knocked down in the retina. So basically, this is a disease of the young males, and things somehow go unnoticed, and the hallmark still remains that the 50 to 60% of these cases present with a vitreous hemorrhage, which subsequently go into the recurrent phase because either the person is not knowing or he's not caring. So these cases come like that. So now I'll be focusing on the etiopathogenesis of this condition. And we know that a hypersensitivity to the extraneous agent, which might be tuberculosis, causes the release of retinal S antigen from the retina, and this leads to an autoimmune inflammatory response. So we had discovered autoimmunity in Eels disease way back in 1999, and this subsequently leads to retinal periphlebitis. There is an enhanced oxidative stress which is associated with Eels, and also there is an associated cytokine profile change. And all these things culminate subsequently into a photoreceptor damage, retinal vascularization, which results from an increase in the VEGF expression. Now, what I've been able to do over the past 20 or 25 years is that we have been able to translate our work into clinical practice. So the laboratory science of ours has led to the development of novel therapeutic strategies in Eels disease. So when we discovered an increase in the T-cell response, this led to the start of oral methotrexate pulse therapy, and that goes well with this. An increase in the oxidative stress led to the start of antioxidant supplementation, which I do regularly for these cases. And the IL-1 beta and TNF alpha were discovered as novel targets maybe 15 years back. And so this immunosuppressive therapy in the form of anti-TNF alpha therapy has also been proposed. But due to the high cost and the lower socioeconomic strata, the patient somehow is not able to undergo these high-ended treatment strategies. Now, 20 years back, we developed an Eales disease classification system which takes into consideration both the inflammation and the neovascularization concept. So this is a simple, easy to recall, and this takes into consideration the clinical and the fluorescein angiography variables, and based on this, we have the disease severity and management strategies. So just to summarize, we have Eales disease per se and the central Eales disease. Now the Eales disease can be divided into 4 stages. Stage 1 is the stage of inflammation, where the retinal periphlebitis is basically involving the small caliber vessels. Stage 1B is a periphlebitis of the larger caliber vessels. Stage 2 is the stage of retinal ischemia and neovascularization, where 2A is retinal capillary non-perfusion, and 2B is the stage of neovascularization in the form of NVE or NVD. And as the disease progresses, the next is the stage of proliferation and hemorrhage, where we have fibrovascular proliferation, and subsequently as the vitreous contracts and this fibrovascular tissue gives way, this leads to vitreous hemorrhage. And finally, as the disease complicates, we have the stage of complications, where this is a tractional or agmatogenous component of the detachment. And as a last stage, the patient may present with rubeosis, neovascular glaucoma, cataract, and optic atrophy. Now, based on these stages, likewise, we have developed and proposed the management strategies. Stage 1, the stage of inflammation, has medical therapy. Stage 2, the stage of ischemia and neovascularization, has either observation or laser. Stage 3, the stage of proliferation and hemorrhage, has either laser or pars plana vitrectomy. And stage 4 of complication requires more sophisticated strategies. So our classification system has had a favorable visual outcome if the patient is treated well, based on this grading and the management strategy system. And now, over the past few years, our classification system has been included in the American Academy of Ophthalmology as the standardized classification system for Eales. So now that is the global standard of care for Eales disease. And all the stages we had proposed 20 years back are now with the American Academy. Now, fluorescein angiography plays a very important role and highlights the things which somehow we are not seeing. And as you can see, that the things are very clearly visible. And we also try to see the relationship between the retinal ischemia and neovascularization. So 20 disc areas will lead to an NVE, and 60 disc areas of CNP will lead to NVD. We also focused on the topographic distribution of retinal neovascularization and found that the superior temporal quadrant was found to have the maximum number of NVEs. Now, macular involvement previously was unknown in Eales, and about 25 years back, I highlighted that macular involvement is not common in Eales, and we presented a series and published a series of 175 patients. So here are some of the examples of macular involvement, and here also we can see the pull on the macula due to the tractional component and an increase in the foveal avascular zone, which might be associated with this condition. Now for Eales disease, we have the medical therapy in form of corticosteroids and immunosuppressives. we developed oral methotrexate pulse therapy, which can be given for a period of 3 months to start with. And the basic concept is that the pulse differs from a chronic moderate therapy and has the ability to reset the aberrant immune response. And also the pulse may just abolish the source of antigens, and the disease to this, the response to this therapy usually starts in about 4 weeks' time. The only precaution is that tuberculosis per se has to be ruled out. Dr. Biswas has already showed in a great work of his that he examined few hundred patients of tuberculosis and did not find vasculitis in even a single case. So his observation has been that TB vasculitis may be a different thing, but here the things are different. So in this slide you can see the response of oral methotrexate pulse therapy. You can see at 12 weeks how the things have improved, and on the right at 6 weeks as the things have started to improve. And we can also use a combination of corticosteroids and a simultaneous methotrexate. The steroids are stopped at about 4 weeks' time when methotrexate starts to pick up, and that goes well. Antioxidant supplementation should be considered because that relieves the oxidative stress and then the cascade of vasculogenesis also. A B scan helps us in defining vitroschisis in some cases where we are planning to do surgery. Here is just an example. Photocoagulation, as we discussed, remains a mainstay of treatment still for the retinal diseases, and things improve after laser therapy, and we can see a residual stock at the level of the disc. Vitreoretinal surgery should be practiced now because the instrumentation has improved dramatically, and previously it was thought that one should wait for 3 to 6 months, but now I feel that in about 4 weeks' time of hemorrhage, the PVD has happened, and if the things are not resolving with anti-VEGFs, etc., then we should go in for surgery for a quicker response. Intravitreal anti-VEGF stays with the disease, and here is just one example to show how things improve after intravitreal therapy. Thank you very much.
Professor Sandeep, thank you very much. It was
sorry I took a bit time, but
questions are very important part.
Yeah.
I was always thinking that why this condition only causes the periphlebitis and doesn't affect the arterioles, you know? Any
Yes,
hypothesis for that, sir?
No, I haven't developed a hypothesis
Yeah.
for that, but then the veins are predominantly involved
Yeah, that's what.
in this, and somehow the left eye also I have observed as already reported that somehow the disease starts from the left eye.
Okay.
Predominantly.
Males.
So that not be the case all the time,
Right,
but
sir.
in the majority of cases somehow.
Sir, and
the
what is the
things are
role of
starting.
AKT as per your experience, sir, in these patients? Like a patient with active eels, if there is some
Active
Montux
eels-
is positive, then would you start AKT in these patients?
Yes, then only I can start because that hypersensitivity thing will go down.
Okay.
So that source which is hitting the retina all the time, that might be a tubercular factor. So that will be helped out. These patients are not frankly tubercular.
Okay.
But I think before the start of this immunosuppressive therapy, one has to be sure that the patient is not having any component of tuberculosis per se.
Fine. Thank you, sir.
Thank you.
Any comment from Dr. Sethi? Yeah.
So one question, sir. Very clearly you mentioned nicely. My question is, clinically, how do you, in your experience, differentiate a tuberculous vasculitis versus an Eales disease? What do you think is something that you will, lean toward the tuberculous vasculitis, irrespective of the other investigations?
Well, what I have seen is that these are the guys from the age of 15, 16 up to the age of 30 years or so. They are practically healthy. So, as per se, you are not thinking of tuberculosis at all. And all the features which we see first time in the eye, they just fall into the Eales disease group, and we have to do this tuberculosis workup definitely. But usually, I've seen that these patients do not turn up to be frank tubercular per se.
Like so,
And the other thing which is a bit thoda sa hatke se, that the diabetic membranes grow horizontally, whereas the Eales will go vertically up from the disc. So that is one, and I've not been able to know that how and why the things are. But just by the look of the eye, you know that this is Eales. Although you have to do all kind of investigations, but that is how the things.
Just one quick comment. Usually we think that's from the capillary to large venules. You said 1A involves large venules, then small venules, then
small
capillary.
then large, yeah.
हाँ, उल्टा है इसमें, ऐसा कैसा है?
नहीं small पहले इसमें आता है.
The capillaries come in stage 1, stage 2, and veins come in stage 1. That is what you have mentioned.
नहीं, that is capillary non-perfusion areas is in stage 2. Stage 1 is periphlebitis only.
Okay.
Sir,
Okay, yeah.
one question I had was, when do you consider doing laser in these patients? What is your
I think
criteria?
laser is just like you do for all the retinal diseases. With the help of medical therapy, the inflammation has to be knocked down first.
No, sir.
Once the inflammation has been knocked down and you find that there are areas of CNPs, and in the majority of cases, 50 to 60% will be having vitreous hemorrhage. So there you have to start with laser.
Sir,
So-
I did not
so like
put my
that.
question clearly. Sir, is there a role of the disc diameters of the capillary non-perfusion areas and
Sir-
doing lasers, or the presence of NVE, NVD is must before we consider laser? Because
good
these
question.
do not bleed as much as the diabetics.
Yes. So as I had shown, that was more for research कि आपका 20 disc area और जो है 40 disc areas.
Yes.
But once you have done fluorescein और आपको एक mentally लगा कि ये तो 40 area के आसपास जा रहा है, then you have to see that the patient can come on follow up or not, and then you have to decide. आपको नापना नहीं, नापना तो रिसर्च के पॉइंट ऑफ व्यू से एक आपको ग्रॉस आइडिया हो जाता है कि यहाँ पर NVE हो सकता है या NVD हो सकता है, and so on.
Yeah, he mentioned about that CNP
Thank you, sir.
20 diopter and 20 disc
Yes,
and
yes.
8.
And
That's a
40,
very good thing. I think.
This
We can
disease
use
is
in diabetic
male dominance.
retinopathy also.
No, in female incidence is less. Is there any hormonal factor?
Hormones
Why-
I haven't studied, but I feel that since the males are out of the house, exposed and all those things,
Yeah.
और अपने देश में हवा में ही ट्यूबरकुलर तो है ही, हम लोग को जो है ट्यूबरकुलोसिस नहीं है, लेकिन हवा में ट्यूबरकुलोसिस
TB है।
So उसी
हवाओं
की
में TB है।
उसमें हवा उसकी जो है हाइपर